Finals SAQ31, Renal Transplantation, CKD and AKI. The case. A patient is to receive a cadaveric renal transplant. A. Detail the aspects of your preoperative assessment specific to chronic kidney disease. This includes issues related to CKD itself, underlying cause of CKD, which may be diabetes mellitus 40%, hypertension 24%, glomerulonephritis 7%, chronic pyelonephritis 5%, polycystic renal disease 4%, and unknown cause 20%, management of CKD, and implications of possible previous transplant. Airway. Some causes of CKD may contribute to a difficult airway such as scleroderma. Respiratory. Assess for fluid overload. The patient may be immunosuppressed due to drug or disease. Assess for respiratory infection. CAPD fluid should be drained preoperatively as it may cause diaphragmatic splinting, vasoatelectasis, and shunt. Cardiovascular. Patients with CKD are at risk of accelerated coronary artery disease. Assess for symptoms. Check recent ECG. IHD may be silent, especially in diabetics. Hypertension may be underlying cause or result from CKD. Check for end organ damage in the form of left ventricular hypertrophy on ECG and echo. Fistula or vas caths must be preserved. Do not cannulate or take blood pressure on fistula arm. Avoid pressure on it intraoperatively. CKD patients are at risk of calcified valvular lesions resulting in stenosis. Assess for symptoms, auscultate heart sounds, and echocardiography if indicated. Have up-to-date ECG, echo, and exercise testing. There is increased risk of left ventricular failure. Pericardial effusions are rare if dialysis is effective. Neurological. Autonomic neuropathy related to uremia and diabetes mellitus may be present. There is risk of delayed gastric emptying and possible need for proton pump inhibitor, pre-medication, and RSI. Endocrine. If the patient has diabetes mellitus, use variable rate insulin infusion. In the absence of diabetes, the patient may still have impaired glucose tolerance due to steroid treatment. If having steroid treatment, there may be need for perioperative supplementation. Patients may have secondary hyperparathyroidism. Check calcium and phosphate levels. Pharmacology. Succinylmetonium for RSI may be contraindicated if potassium is elevated. Variable rate insulin infusion if diabetic, or management of oral hypoglycemic agents according to AAGBI guidelines. Omit ACE inhibitors or ARBs prior to surgery to avoid hypotension. All other antihypertensives may be continued. If the patient has previous transplant, they may be taking steroids or other immunosuppressives. Even if transplant has failed, these drugs need to remain therapeutic to avoid rejection. Seek advice from renal physician regarding dose preoperatively while nil by mouth. GI. Consider autonomic neuropathy due to CKD or diabetes. Pre-medication with PPI or RSI may be needed. Hematology. The patient may have anemia due to a variety of reasons such as chronic disease, impaired erythropoiesis, blood loss from dialysis, and GI losses. Check full blood count and GSH. Aim for HB 80 to 100 grams per liter. Transfusion may worsen hypertension and precipitate heart failure. INR and APTT and platelet count are usually normal. Dialysis improves coagulation once heparin has worn off. There is tendency to thrombosis in fistula in stage G5 CKD on hemodialysis. Thrombocytopathy associated with renal failure may contraindicate regional anesthesia. This is improved with dialysis and therefore unlikely to be an issue. Uremia affects platelet function and causes prolonged bleeding time. Thrombocytopathy is not corrected by platelet transfusion, but may be improved by cryoprecipitate or desmopressin. Immunity. These patients are susceptible to infection due to immunosuppression of disease state and/or drugs. Check for possible infection. Renal. Assess fluid status. Some patients with CKD are anuric, some still pass urine. Ensure patient is not hypovolemic if recent hemodialysis. as this increases the risk of perioperative hypotension. Signs of hypervolemia includes dependent edema and basal crepitations. Assess dialysis record, dry and wet weights. Signs of hypovolemia includes postural hypotension, low JVP, thirst, poor skin turgor, and oliguria. Check electrolytes. The patient may require hemodialysis preoperatively. Abnormalities predisposed to arrhythmias. Ensure timely renal replacement therapy preoperatively. A recent serum potassium is essential. If it is more than 6 millimoles per liter, dialysis will be required. Drugs causing raised serum potassium includes succinylmetonium, NSAIDs, beta blockers, ACE inhibitors, spironolactone, tacrolimus, and cyclosporine. Serum sodium may be low due to water retention. Hypocalcemia and hyperphosphatemia are common but rarely symptomatic. A mild metabolic acidosis is frequent. The ability to compensate for further acidosis is poor. The patient may have central line or fistula. Avoid damaging the fistula. Allow 4 to 6 hours to elapse after hemodialysis prior to surgery. This allows fluid compartment equilibration and metabolism of residual heparin. Indications for urgent dialysis includes hyperkalemia, fluid overload, acute acidosis, and symptomatic uremia. If volume overload occurs postoperatively, the patient will need extra dialysis. If major surgery, plan post-op care with renal and ICU teams. B. How can the function of transplanted kidney be optimized intraoperatively? Airway and respiratory, optimize gas exchange to support oxygen delivery, minimize risk of respiratory acidosis. Cardiovascular, optimize filling with cardiac output monitoring and CVP monitoring, aim for 12 to 14 cmH2O. Aim for normal tension and a higher MAP such as 90 mmHg in hypertensives. Adequate patient warming to avoid vasoconstriction. Endocrine, glucose control if indicated. Pharmacology, avoid nephrotoxins including starch solutions. Immune and infection, early commencement of immunosuppression. C. How may this patient's postoperative pain be optimally managed? Regular pain assessment and management of anxiety through explanation and reassurance. Regular paracetamol. NSAIDs are contraindicated. Wound catheters and LA infusion may be considered. PCA fentanyl is suitable as fentanyl does not have active metabolites that are excreted via the kidneys. Epidural analgesia are used in some centers, but this may be contraindicated by recent heparin administration for dialysis. There is a need to ensure that hypotension via epidural analgesia does not result. D. Explain why some common postoperative analgesic drugs should be avoided. NSAIDs reduces renal perfusion due to reduced prostaglandin synthesis. Poor perfusion results in poor renal transplant function. NSAIDs may be directly nephrotoxic. Morphine is metabolized mainly in the liver to active metabolite M6G that are excreted by the kidney. Post-op renal impairment may result in accumulation of these metabolites, causing drowsiness, hypotension, and respiratory depression. Smaller doses with longer dosing intervals for short time periods of morphine are acceptable. Codeine and dihydrocodeine have active metabolites that are renally excreted and increases the risk of opioid toxicity and should be avoided. Oxycodone has active metabolites that are renally excreted. Accumulation of these metabolites in renal failure leads to opioid toxicity, and oxycodone dose should be reduced. Petidine and its active metabolite norpetidine are renally excreted, which accumulates in renal failure, and petidine is thus contraindicated. Included here are dosage adjustments for select opioids in renal insufficiency. If GFR is more than 50 mL per minute, morphine, oxycodone, methadone, and fentanyl may be given at usual doses, but hydromorphone or hydrocodone should be reduced to 50%. If GFR is between 10 and 50 mL per minute, morphine dose should be reduced to 50 to 75% of normal dose, hydromorphone and oxycodone 50% of normal dose, methadone 100% of normal dose, and fentanyl 75 to 100% of normal dose. If GFR is less than 10 mL per minute, morphine dose should be 25 to 50% of normal dose, hydrocodone 25% of normal dose, avoid oxycodone, methadone 50 to 75% normal dose, fentanyl 50% normal dose. Additional information. Weaker candidates tend to ignore the anesthetic implications of diseases which leads to CKD, the importance of preserving dialysis catheters and fistula sites, implications of a prior failed renal transplant and any associated immunosuppressives, and the need for pre-op investigations. CKD. CKD is defined as kidney damage or abnormalities of kidney structure resulting in GFR of less than 60 mL per minute per 1.73 meters square for 3 months or more. CKD may be classified based on GFR and the level of proteinuria. Patients are classified as G1 to G5 based on GFR and A1 to A3 based on albumin to creatinine ratio. The higher the stage and the greater the amount of protein present in the urine, the more severe the CKD. For stages of renal dysfunction by GFR, GFR category G1, GFR is 90 or more. For GFR category G2, GFR is between 60 and 89. For category G3A, GFR is 45 to 59. GFR category G3B, GFR is between 30 and 44. For G4 category, GFR is between 15 and 29. For G5 category, GFR is less than 15. Pre-op care of CKD patients has been mentioned in A. Perioperative care. All aspects mentioned in A applies, including additional highlights in the following. Airway. Delayed gastric emptying due to autonomic neuropathy and increased gastric acidity makes gastric reflux more likely. Most patients are on H2 blockers and PPIs. RSI is reserved for patients who are not adequately fasted or who have symptomatic reflux. C. Venous access and fistula. Many patients have upper limb AV fistula. Avoid cannulation and NIBP in this arm. Protect fistula arm with padding. Try to cannulate the dorsum of the hand to avoid damage to veins in the forearm and antecubital fossa. Use dialysis catheters for IV access only as last resort. The dead space may contain high-dose heparin, aspirate and discard. Arterial cannulation may compromise future AV fistula formation and should only be used when absolutely necessary. Fluid and electrolyte balance must be carefully managed. Many patients have some residual renal function and urine output. Maintaining this is essential. Normal volemia is ideal. Replace fluid losses promptly and avoid hypotension. If large fluid shifts are likely, CVP or esophageal Doppler monitoring is useful. These patients may have had multiple CVP lines, hence use ultrasound. Avoid femoral vein in patients suitable for transplants and in subclavian veins in those needing dialysis as incidence of stenosis is high. The type and volume of fluid administered affects renal outcome. Dynamic measures of fluid responsiveness, such as straight leg raise and pulse pressure variation, are better at gauging fluid deficit in these patients. There is little evidence on which fluid is best in perioperative setting. Current literature supports the use of balanced crystalloid solutions rather than high chloride solutions in critical care environments. Albumin solutions can be indicated in renal patients with high fluid demands to lessen interstitial fluid overload. Safe drugs in CKD includes midazolam, temazepam, lormetazepam, propofol, isoflurane, desflurane, halotane, saxametonium if serum potassium is not high, atracurium, cisatracurium, alfentanyl, remifentanil, bupivacaine, lidocaine, and paracetamol. Drugs safe in limited or reduced doses includes ketamine, etomidate, thiopental, sevoflurane, vecuronium and rocuronium, fentanyl, morphine, and oxycodone. Contraindicated drugs include enflurane, pancuronium, petidine, codeine, tramadol, and NSAIDs. Most drugs are excreted by the kidneys either unchanged or as metabolites. Loading dose of drugs are often unchanged, but maintenance doses should be reduced and/or dosing interval prolonged. Hypoalbuminemia and acidosis increases the free drug availability of highly protein-bound drugs. Most anesthetics reduce renal blood flow, GFR, and urine output. Analgesics. Most opioids are excreted by the kidneys and so have prolonged duration of action in CKD. Morphine. Long-acting morphine metabolite M6G has greater potency than morphine itself. M6G accumulates in renal failure. Petidine. Avoid petidine as its metabolite norpetidine can cause convulsions. Fentanyl. Fentanyl has inactive metabolites but accumulates with prolonged use. Alfentanyl and remifentanil may be used in normal doses. Codeine and dihydrocodeine half-lives are prolonged 5 times, hence avoid. Oxycodone has active metabolites, so reduce the dose and increase dosing interval. Tramadol and its active metabolites are renally excreted, and the manufacturer does not recommend its use in end-stage renal failure. PCA, morphine, or fentanyl can be used but with caution. In theory, the reduction in excretion increases plasma concentration, thus reducing demand. Paracetamol is safe in normal doses. Avoid NSAIDs even if anuric. Induction agents. Reduce doses of benzodiazepines, thiopental, and etomidate by 30% due to changes in protein binding, VD, and cardiac function. The dose of propofol required for BIS of 50 is increased. Wake up following propofol infusion is faster. The elimination of volatile anesthetic agents is not dependent on renal function. Isoflurane, halotane, and desflurane are all safe. Sevoflurane is safe for induction but will produce inorganic fluoride ions with prolonged use. Avoid more than 4 hours total. Muscle relaxants. Succinylmetonium is contraindicated in the presence of elevated serum potassium. Plasma cholinesterase activity is unchanged in CKD. Etracurium and cisatracurium are logical choices. Vecuronium and rocuronium can be used as single doses but with prolonged duration of action. Mivacurium clearance is reduced. Always use peripheral nerve stimulator to assess degree of neuromuscular blockade. Sucamadex is excreted in the urine unchanged, but its action does not depend on renal excretion. Sucamadex appears to be safe to use in severe CKD, but it is not recommended for GFR less than 30 mL per minute, as clearance may take much longer and repeated muscle relaxation with rocuronium may be needed. Sucamadex is unpredictably removed by dialysis. Reversal agents. Excretion of neostigmine, sucamadex, and glycopyrronium are prolonged in CKD. LAs. LA peak effect and their metabolites may accumulate during prolonged infusions. Taken together, this may result in rapid attainment and maintenance of high peak concentrations and accumulation of metabolites, especially with continuous infusions. This may predispose to a higher side effect risk profile. Reduce maximum doses of LA by 25% due to reduced protein binding and lower CNS seizure threshold. Epidurals and spinals work well, but consider the increased risk of hypovolemia after dialysis, hemorrhage, and spinal hematoma formation. LAs are not dialysable. Antibiotics. Most antibiotics are excreted by the kidney. It is common to use a normal loading dose with reduced and/or delayed maintenance dose. If in doubt, check British National Formulary or consult microbiologist. Immunity. Sepsis is a leading cause of death in CKD. Inhibition of humoral and cell-mediated immunity occurs. Careful attention to asepsis is required for all invasive procedures. Hepatitis B and C are common. Kidneys. Hyperkalemia is worsened by acidosis, so avoid hypoventilation and hypercarbia. Post-op care. Any patients with CKD are at increased risk of developing AKI. Prevention is most important. Post-operatively, renal function must be checked. Liaise carefully with the renal unit about timing and need for dialysis post-operatively. Use epidurals with caution. Prescribe analgesics carefully. Pay attention to fluid balance. Avoid nephrotoxic drugs. PD. Peritoneal dialysis uses large surface area of the peritoneum to exchange fluid and metabolites via temporary or permanent Tankhoff catheters in the lower abdomen. It is inefficient but can run continuously. Catheter placement or removal usually requires a mini laparotomy but can be done under LA with or without sedation. Dialysis fluid should be drained before anesthesia to prevent respiratory function compromise. Patients can usually omit 24 to 48 hours of post-op dialysis, but a period of hemodialysis may be required if undergoing bowel surgery. AKI. Acute kidney injury is defined as any of the following: increased serum creatinine by 0.3 mg per dl or more, or 27 micromole per liter within 48 hours, or increase in serum creatinine by 1.5 times or more the baseline, which is known or presumed to have occurred within the prior 7 days, or urine volume of less than 0.5 ml per kg per hour for 6 hours. AKI may be categorized according to RIFLE, Acute Kidney Injury Network, or KDIGO definition systems. For the RIFLE criteria, stages includes risk, injury, and failure. For the risk stage, there is increased serum creatinine of 1.5 times or GFR decrease of more than 25%, or urine output reduced to less than 0.5 ml per kg per hour for 6 hours. The injury stage is characterized by increase in serum creatinine of times 2, or GFR decrease of more than 50%, or urine output less than 0.5 ml per kg per hour for 12 hours. The failure stage is indicated by increased serum creatinine of 3 times, or GFR decrease by 75%, or serum creatinine is 4 or more mg per dl when serum creatinine is in acute increase, or urine output less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. According to Acute Kidney Injury Network classification, for stage 1 there is increase in serum creatinine of 1.5 to 2 times, or serum creatinine increase by 0.3 or more mg per dl, or urine output less than 0.5 ml per kg per hour for more than 6 hours. In stage 2 there is serum creatinine increase of 2 to 3 times, or urine output less than 0.5 ml per kg per hour for more than 12 hours. For stage 3, serum creatinine is increased by 3 times or more, or serum creatinine increased by 4 or more mg per dl when serum creatinine is in acute increase, or urine output less than 0.3 ml per kg per hour for more than 24 hours, or anuria for 12 hours. For KDIGO, stage 1, there is increase in serum creatinine by 1.5 to 1.9 times that is known or presumed to have occurred within the preceding 7 days, or serum creatinine increase 0.3 or more mg per dl within 48 hours, or urine output less than 0.5 ml per kg per hour for 6 to 12 hours. In stage 2, there is serum creatinine increase by 2 to 2.9 times, or urine output less than 0.5 ml per kg per hour for 12 hours or more. In stage 3, there is increase in serum creatinine by 3 times, or serum creatinine increased by 4 or more mg per dl, or initiation of renal replacement therapy, or GFR decreased to less than 35 ml per minute in patient less than 18 years old, or urine output less than 0.3 ml per kg per hour for 24 hours or more, or anuria for 12 hours or more. Anesthetic considerations. Preoperative. Identify patients at risk. Avoid and manage risk factors and etiologies of AKI. Risk factors for perioperative AKI includes patient-related factors, nephrotoxins, and procedure-related factors. Patient-related factors includes comorbidities such as hypotension, hypovolemia and dehydration, sepsis, obesity, diabetes mellitus, CKD, CVS and hepatobiliary diseases, pulmonary disease, rhabdomyolysis, increased intra-abdominal pressure, cancer and urinary obstruction. Old age, neonates, male sex, increased ASA score, critically ill patients, previous AKI, steroid use, neurological or cognitive impairment affecting diet are risk factors for perioperative AKI. Nephrotoxins includes NSAIDs, antibiotics, ACE inhibitors, radiological contrast media, lithium and chemotherapy agents. Procedure-related factors include major surgery, emergency surgery, cardiac surgery, and use of contrast dye. Etiologies of AKI may be classified as pre-renal, intrinsic, and post-renal. Examples of pre-renal causes of AKI include hypovolemia, sepsis, cardiac failure, increased intra-abdominal pressure, cirrhosis and hepatorenal syndrome, aortic cross-clamp, hypotension, and nephrotoxins. Intrinsic causes of AKI includes inflammation, patient comorbidities, drug-induced, nephrotoxins, acidosis, infection, cardiopulmonary bypass, anemia, packed red blood cell administration, hydroxyl ethyl starch solutions, and chloride-rich solutions. Post-renal causes include tumor, prostatic enlargement, calculi, blood clots, neurogenic bladder, iatrogenic damage, etc. Correct anemia before surgery when possible according to patient blood management protocol. Preoperative rehydration is essential and avoid fluid deficit. Useful tests include eGFR and serum creatinine, which are major initial measurements for diagnosis of AKI. Serum urea is less specific as it is increased in dehydration, GI bleeding, sepsis, and excessive diuretic use. Check serum electrolytes, especially potassium. Check and treat for hyperglycemia. Urine electrolytes may help differentiate hypoperfusion from acute tubular necrosis, but these results are meaningless if diuretics have been given. Medications. Stop nephrotoxic drugs such as NSAIDs, ACE inhibitors, ARBs, and potassium-sparing diuretics. Metformin may accumulate and cause lactic acidosis. Aminoglycosides should be avoided. Contrast-induced nephropathy should be predicted and avoided if possible. Volume loading with crystalloid or sodium bicarbonate may be helpful if contrast is used. Oral acetylcysteine may also be useful. The outcome for polyuric AKI is better than oliguric AKI. Diuretics should be used to manage fluid overload but usually are not indicated in AKI. There is no evidence to support the use of low-dose dopamine. Mannitol may improve urine flow. Other aspects as per CKD. Intraoperative. Choice of fluid solution. Avoid starch solutions if possible. Balanced crystalloids may be superior to chloride-rich solutions in preventing AKI. Fluid management. Aim to prevent further deterioration of renal function. Try to maintain adequate urine output of more than 0.5 ml per kg per hour. Use of intraoperative urinary output as a guide to fluid administration may not be beneficial. Avoid the use of diuretics unless there is a need to treat volume overload. Use measures during surgery to avoid blood loss and unnecessary packed red blood cell transfusion. Watch out for blocked urinary catheter. Hemodynamic goals. An adequate blood pressure is needed for renal perfusion, and this is relative to patient's baseline BP. Avoid low MAP even for relative short periods of time. Inotropes may be required. Evidence so far do not recommend the use of one vasopressor over the other. Invasive monitoring may be needed. Post-op care. Intra-abdominal hypertension can occur following major abdominal surgery and cause anuria by direct compression of renal pelvis and reduced renal perfusion. Seek advice from the renal unit or ICU about post-op care and dialysis if hyperkalemic, acidotic, having symptomatic uremia, or having fluid overload. For further reading, one may refer to the BJA publication by O'Goran and Imatop, Perioperative Acute Kidney Injury in 2015. Renal Transplantation. The duration of this procedure is 90 minutes to 180 minutes. Position is supine. Pain is severe. Blood loss is minimal to 500 ml. Typical technique is GA with endotracheal tube, positive pressure ventilation, and CVP monitoring. Preoperative considerations. Usual problems related to CKD and uremia as mentioned previously. Chronic anemia is common. Ischemic heart disease is common and should be assessed and treated. Recent hemodialysis may have been administered. Some degree of hypovolemia is common. Check post-dialysis investigations, especially serum potassium. Perioperative. Avoid damaging AV fistula. Gentle fluid load prior to induction. Wide swings of arterial pressure may occur. Commonly used agents that are safe in renal failure includes fentanyl, remifentanil, propofol, atracurium, and sevoflurane. Consider CVL under ultrasound guidance to monitor CVP. Avoid subclavian vein. Consider arterial line. Prior to graft reperfusion, administer fluid to increase CVP to 12 to 15 mmHg and MAP of more than 80 mmHg to optimize perfusion. Ephedrine or metaraminol may be used. Maintain normothermia. Many centers administer diuretics such as mannitol and furosemide and immunosuppressants such as methylprednisolone prior to graft reperfusion. Check for local protocols. Avoid blood transfusion if possible. Blood transfusion may be needed if HB is less than 8 grams per dl. Post-op care. Regular paracetamol and PCA is usually adequate. Fentanyl PCA is preferred. Be cautious with morphine. Epidural and spinal is not usually necessary. There is increased risk of bleeding on insertion, and epidurals may cause hypotension. Consider tap block. Avoid NSAIDs. Monitor CVP and urine output hourly. Maintain hypervolemia to promote diuresis. Many units have protocols. Anesthesia for AV fistula formation. Ask the surgeon where the fistula is to be formed. Local infiltration works well for brachiobasilic fistulae. An axillary or supraclavicular brachial plexus block is recommended for a brachiocephalic fistula. Evidence show a better fistula outcome. Patients may need extra LA in the axilla and mild sedation. Avoid hypotension to prevent fistula thrombosis. The fistula may be used for dialysis after 3 to 4 weeks. Synthetic grafts can be used immediately but do not last as long. These are my references. Thank you.